session introduce our speakers. Thank you.
So good evening, everyone, and welcome to today's webinar. So thank you for joining. We have a fantastic program lined up, focusing on case-based discussions and clinical strategies. So now let's begin with our first case presentation. I'm very pleased to welcome Dr. Prasad, who will kick off the clinical discussion with the first case. So Dr. Prasad, the floor is yours.
Thank you so much, and thank you so much for having me here. This is really a special program. So I'll be talking to you a little bit about a left main trifurcation case and some interesting challenges that came about actually pre and post PCI. And really one of the main take-home points from this is sometimes the pre-planning before you bring a patient to the cath lab can help optimize what you do in the cath lab and to illustrate whether or not support is needed for all left main cases. So this is an 82-year-old, very frail man with multiple risk factors, increased BMI of 40, hyperlipidemia, hypertension, who presented to an outside hospital with chest pain radiating to his left arm. He actually initially presented with the chest pain and was sent home, thought to be secondary to some AFib they saw. And then he came back to a different center, had troponins drawn in an ECG, which were both concerning, went to the cardiac cath lab at an outside center, found to have 3-vessel disease, and was then sent to us. When he was sent to us, his blood pressures were in the 90s, over 60 systolic, so a little bit hypotensive initially. And we waited sort of a few hours before we got the read on his angiograms, the actual films, and his troponins remained stable when we saw him. So you can see here, when we got the films a few hours after arrival, the RC looks like there has some calcified sort of proximal and mid disease and sort of a diffusely diseased vessel, but really proximal and mid. Nothing on this was jumping out to us as sort of necessarily the culprit, but it can be hard to tell in these cases. We then noted this distal left main lesion that sort of went into this proximal circumflex and proximal LAD. And there's also some ramus disease, as you can see here. And that'll be opened up a little bit better here. And so it looks like there is a trifurcation with sort of 3 different vessels being involved. And our hope was, if we're going to treat this percutaneously, then we may be able to avoid at least one of the branches to avoid too much metal on metal. This is a apicranial, areocranial of the LAD, and you can see that, it's really more the proximal vessel, and then the distal vessel sort of recovers with a little bit of diffuse disease distally. So on arrival, the patient was hypotensive, initially in the ED in the 90s and 60s, but became progressively more so hypotensive, requiring multiple vasopressors, was admitted to the CCU complaining of chest pain with anterior ST depressions. The creatinine was 3.7 on arrival, and the interventional team was called to consult emergently for possible plan to go to the cath lab immediately. By this point, we did have the films, and we did a bedside echo, which showed a large pericardial effusion and actually a preserved EF of 50%. Based on that large pericardial effusion, which did seem to be causing some RA and RV collapse, we did a bedside pericardiocentesis because the pressures continued to drop, and he was on max pressors by this point, and we retrieved 800 cc's of bloody fluid. It was unclear etiology where that might have been from, and we sent the fluids, and we didn't actually get much in the way of that, but that was removed. And he actually had immediate improvement in his hemodynamics and his clinical status. With that clinical stabilization, we then were sort of deciding whether or not to move directly to the cath lab versus not. I would love to hear the thoughts of the panel, just sort of quickly, cath lab or stabilize in the CCU.
Yeah, so this is really a great question, actually, because now we have actually 2 different diagnoses in this patient. A clear 3-vessel disease with a left main involvement and a second cardiac disease with unclear etiology. So if you are asking me, actually, if the patient does not have any chest pain, we could postpone the procedure. That's my opinion. So
Yeah.
so you think and what the panelists do believe? Dr. Raab, what's your opinion? You're mute. You are mute. So just unmute.
So the patient, if he has a bloody pericardial effusion, you want to make sure he doesn't have cancer, but that really changes the whole outlook, whether to offer any kind of therapy or not. You always have to worry about metastatic cancer. Secondly, are you going to anticoagulate the patient with a bloody effusion? And thirdly, did the patient have enough of an infarct to leak blood from a small perforation in the pericardium? So those are my thoughts. And so I would want a little more time to address that before to be jumping the procedure.
Mm-hmm. And Dr. Paradis, what do you believe?
Yeah, indeed, I agree with what we just said. First of all, we need to stabilize the patient from an hemodynamic perspective before jumping into a procedure, but also exclude any mechanical complication of myocardial infarction. That's a priority. Pericardiocentesis, I mean, I'm more comfortable doing it in the cath lab because I have all the equipment and I do it on X-rays, but that's not meaning that I want to jump on the procedure. Just I want to stabilize the patients and then consider further steps.
Well,
Absolutely. So those are all great thoughts and a lot of what went through our mind. So because the patient was stable, not having chest pain at the time, and because of this new finding, we decided to take him to the CCU, get a formal echo first and foremost to rule out any, any sort of mechanical complication, because we were worried that this was sort of tamponade from a free wall rupture or something like that. That actually ended up being negative. It was an EF of 50%. We didn't find any VSDs. We didn't find any free wall ruptures, which was interesting. We did a pan scan, just a CT pan scan, just to see if there were any obvious malignancies, and then obtained his outside records over the next 24 hours with his most recent colonoscopy, and didn't find anything to suggest malignancy there. And then the other aspect of this was that his creatinine was 3.7. And so the thought was, is this a case that we want to immediately go into a PCI without sort of stabilizing the creatinine and see where that's going? And then, of course, he is older and frailer. We didn't think he'd be a great surgical candidate, but before proceeding to left main PCI, we got a surgical consult. So that's a little bit about what we did in the CCU initially. 2 days later, he went into AFib with RVR with some anterior ST depressions. His creatinine was still 3.7. His LFTs had climbed to 3,000. And at this point, we were sort of deciding between, again, emergent CABG, but he was turned down for CABG previously before, emergent PCI or medical management, and possible future intervention. So we decided to go with continuing to stabilize him, because we thought that whatever minimal chest pain he had was from the AFib with RVR. So we continued to medically manage him for several days. His creatinine nicely came down to 1.6. His LFTs improved. We were able to have a more appropriate heart team discussion at that point, with the kidneys being less of a factor. And he was deemed too high risk for CABG. And so that's how we decided to plan for a cath lab for intervention. During this time, we, of course, continued to look for any sources of malignancy, and serial trialed him on heparin, as well as, after he was turned down for CABG, on DAP to see if he bled again from the pericardium. And then the pericardial drain was removed. And when his serial echo stayed stable, the drain was removed, and then the plan was for cath lab for intervention. So this all happened over the period of about 7 to 10 days. To plan the PCI, we knew that he had sort of poor access in the setting that of poor pulses, but we did perform iliac and axillary subclavian ultrasounds, which showed adequate caliber and patent vessels, to the point where we did think we could place support if we needed it. But after multiple echoes and this pericardiocentesis had been performed, his blood pressure had ranged in the 130s to 160s, and we decided to bring him down to the cath lab and started with the right heart cath to decide on whether or not the patient needed support. We did a right brachial access, just to sort of, in case he needed more optimization, so we weren't accessing the groins yet and putting in any support yet. And his right atrial pressure was 1, mean PA of 12, with a SAT of 59% and an index of 3.8 and a wedge of 0. Based on this, we felt that he was very well compensated, and even though we were planning a left main trifurcation PCI, we felt that he was well compensated enough that we could monitor his wedge and his PA diastolics with the swan up, to try and decide whether he would need support during the procedure. especially if we needed to do atherectomy, but we did not place upfront support. So our plan was no hemodynamic support. We went back and forth a little bit as to whether we should place the femoral access, but because of his calcified vessels, his age, and the fact that he was moving around a lot on the table, sometimes we felt that second access can cause a little bit more issues than necessary. And so what I did is I just left the swan up and continued to monitor through the case. So as you can see, the swan is in place. This is our guide catheter in, and we're taking a look at the vessels and sort of getting our own first set of pictures. I went radial in him because I preserved a groin for access, and the way he was moving his legs with his restless legs, I felt that would be a better approach. And from a bleeding standpoint, I preferred the radial artery for this. So this was a 7 French radial approach with an EBU 3.5 guide catheter. In this view, actually, the left main did not look terrible. And we took another view here. I should mention that with the creatinine of 1.6, we did begin gentle hydration according to the Poseidon protocol, so half of what the Poseidon protocol recommended, just to monitor, to make sure that he didn't end up with any AKI after the procedure. We placed a Xi'an blue in the LED, exchanged that for a Viper Flex, and then proceeded with orbital atherectomy of the LED initially. And the reason for this was the IVUS didn't cross, and that's generally sort of an indication to me that if the IVUS isn't crossing a 5 French low profile, IVUS doesn't cross, and we typically then reach for either rotational atherectomy or orbital atherectomy. In this case, the decision for orbital atherectomy was made in the setting of triple vessel disease and concern for any sort of hemodynamic compromise despite his EF being normal. So we then wired into the ramus and performed orbital atherectomy there and did the same into the circumflex. The circumflex was a little bit more challenging to wire, but we were sort of direct wiring with the Viper wire, which had sort of just been modified at the time. And then this is orbital atherectomy of the circumflex. We went ahead and proceeded with a balloon. We opted for a culotte strategy, and so we started with an NC balloon in the LED and NC balloon in the circumflex, and did a gentle inflation just to 12 atmospheres in the ramus because we did not want to commit to treating this if we didn't need to, but this was just to allow IVUS to sort of pass and make room in all 3 directions. So we performed IVUS of the circumflex, the LED, and the ramus. For the interest of time for this session, I haven't included the IVUSs of all of these, but you can see here that we do, after the OAS plus the ballooning, we do have what we felt was adequate calcium fracture, as you can see here, to the point where we did feel comfortable going in. You can see the bifurcation coming in there, but we did feel comfortable proceeding with our culotte based on the calcium fracture, because that was the main thing that we were trying to do both with OAS and the balloons afterwards. So that sort of was the bulk of the calcium here. And there were reverberations suggesting calcium fracture. And we did this in all 3 vessels and confirmed that. And then this comes into the left main. We marked our sort of landing zone in the left main. So we proceeded. Yes.
Just to ask, so for lesion preparation, which sizing of the balloon have you been using? Just like 1:1 arterial ratio based on your IVUS, or 1 step down, or cutting balloons?
Yeah, so cutting balloons I'll use if I don't get fracture on IVUS, but in this we used what we assumed was 1:1, and it ended up being 1:1 in the LED and the circumflex, or sorry, the LED and the ramus, and the circumflex was small, so then we went back with the 3.0 balloon in the circumflex. So, and and the reason was there was some negative remodeling into the proximal part of the vessel. So I could have gone bigger, but there was an area of negative remodeling. So that's why I didn't take sort of 3.5s all the way across.
Okay, super, thank you.
Megan, we just need to keep track of time, okay?
Yes. So we went ahead and did further inflations according to our IVUS, as you can see here, with larger balloons, as you mentioned, and then placed a stent first in the angulated branch, which was the circumflex, did a 408 millimeter NC balloon pot, then went ahead and placed our LED stent. Based on IVUS, it was not necessary to stent the ramus. We rewired the circumflex according to our bifurcation strategy, and then did a pot here. This was our second pot. And you can see here that this is the circumflex being rewired. It was initially difficult to pass equipment, so we did serial balloon inflation, starting with the Takeru balloon up to a 3015 NC balloon, using a balloon here in the LED as an anchor to help us deliver equipment, and then ended with the final kissing inflation. And then performed IVUS in both directions. Angiographically, the ramus didn't look compromised. So this is after our final angiography, and we had good stent expansion with no edge dissections in the LED or the circumflex, and got a good angiographic result. And the key take-home points from this case, and the reason I decided to present this is I thought it was an unusual case of, a patient comes in with hemodynamic collapse sort of at the start of the procedure, and it's very tempting to rush them straight to the cath lab, but this is a case where I'm glad that we started with the bedside echo, identified an unusual cause of hypotension in a patient with an NSTEMI, started with the pericardiocentesis, and one of the main take-home points was also that we need to sort of, as interventionists, think more about the patient as a whole, as opposed to what we do specifically in the cath lab. Right heart cath and hemodynamics can be very important to plan a PCI, but sometimes waiting can also allow a patient to become more primed and ready for a procedure like this. 7 French for complex bifurcation disease can be very useful. It made the procedure very careful. You saw our use of the anchor balloon for support to get our equipment down. And then from a CKD standpoint, hydration and waiting till the patient is ready from a kidney standpoint can make a huge difference. This patient actually had an improvement in their creatinine, likely because of hydration, to 1.2, and was discharged and followed, and 6 months later had a creatinine of 1.0 with no residual symptoms. So with that, I will turn it over for any questions. Thank you very much.
Thank you very much. We'll move very quickly to Valeria, so if you could stop sharing, Valeria will pick up. But in the meantime, as she's getting ready, a couple of things. The question was asked whether you worked with the ramus and why didn't you stent it? I think to the person who asked the question, many times vessels will stay open even after atherectomy or cutting balloon. The question I've asked our European colleagues: would you have used a drug-coated balloon in the ramus, Valeria or Rolanta? Would you have done that in Europe?
Definitely.
Yes, definitely.
Yes. Okay. All right. So more to come. So for vessels, you don't stent with drug-coated balloon, maybe one. Anyway, so go ahead and introduce the next speaker, Rolanda.
Yeah, so Valeria, we are really waiting for your case. So just please walk us through your case.
Thank you so much, and thanks for having me. Indeed, it's a really important session, and I will present a case, a complex bifurcation case. So we're talking about a 72-year-old woman with no cardiac history, hypertension and diabetes as a risk factor. Her weight is 55 kilos with a BMI of 24. She came in with a STEMI in fear, and she was treated in the ambulance with heparin, prasugrel, and aspirin. So this is the index procedure. We usually go via radial. 95% of our procedure in my hospital are radial. So even if it's a primary PCI. So this is the left coronary artery. You can appreciate some disease in a really small caliber marginal caliber, and then you can see clearly that right after the takeoff of the second diagonal, there's a lesion in the mid LED, but there's also some lesion in the shaft of the diagonal, the second diagonal. Now let's move to the culprit lesion. It's clearly the mid RCA with a high thrombus burden. So we proceeded with thrombus aspiration, manual thrombus aspiration with a good result. A DES was implanted and optimized with post-dilatation, and that was the result. And you can see here from a cranial view of the right coronary artery, there's also some disease in the mid portion of the RDP. So at this point, we have the first non-culprit lesion in the mid RDP, as is the lesion in the same territory of the culprit vessel. Angiographically looks intermediate, but there might be some component of vasoconstriction. Then we have the second non-culprit lesion. It's a marginal branch, a small caliber at the ostium of this branch. angiographically look significant, but also here we might have some vasoconstriction. And then let's move to the more challenging lesion. It's a bifurcation LAD D2 with a Medina 111. Also some lesion, as I said, in the mid portion of the diagonal with an angle less than 70 degrees and a similar comparable caliber of the two branches. So probably suitable for a two-stance bifurcation technique. So at this point, maybe we can discuss with the panel what you have considered in this case of multiple vessel disease in the setting of acute coronary syndrome.
Great, maybe I will start. For me, like this bifurcation, I would be really very curious how what's the percentage stenosis of the ostium of diagonal, just to be sure, like going for two-stent strategy, at least in my center, we try to have at least an osteo, like the lesion length of 10 millimeters at least, and at least 50% stenosis. That's my consideration. So imaging for me is the key to decide.
I think I would completely agree with what you just said. Based on your angiographic images, it looks like you may not need to stent the ostium of the diagonal, and you can just, where your arrow points, you can just put a short stent there and provisional into the LAD alone. But intravascular imaging will be the key.
So one of the things in the guidelines, since I was part of that, but total revascularization is our goal now as a class 1 indication after STEMI. Because this is a women presenting interventional cases, what body weight are you uncomfortable with in doing more procedures? I'll tell you, women under 50 kgs just don't do very well. I know you're right at the border of 55, just don't do well in terms of bleeding and having more procedural complications. So those are two things I wanted to ask Valeria, what do you think about low body weight and women and the guidelines, of course. So.
Well, that's a really important point. I mean, I brought up this case because indeed it's a woman with a low body weight, with multiple vessel disease. But if we consider let's say, the anatomical syntax of these patients, which is high, and then we consider eventually after the indeed resolution of vasospasm, and also some small caliber of the other non-culprit lesion, we end up with, as non-culprit lesion, only the mid-LAD, with possibility also to escalate to two-stent strategy in case. But one important reason to perform PCI in this patient was that we discussed the patient with the surgeon, and as you see also the distal part of the LAD, as usually happens in women, is very also very small caliber. So the surgeon did not consider this peripheral part of LAD suitable for bypass. And of course, what you just said, what you just mentioned, low body weight, that's also a contraindication, important contraindication for, it might be like a risk factor for increased post-procedural complication, bleeding complication.
So I don't disagree with Arasi or Jolanta about the ostium or the diagonal angiographically. But of course, you are the expert. You did imaging guided, stent technique. Angiographically, I could have left it alone and then as a provisional, just stented some of the body of the diagonal, or even maybe did a pressure wire on the diagonal to make sure it's relevant or not. Anyway, that's my.
Thanks. All your points are very relevant, and let's see how I proceed. Indeed, after showing that there was a resolution of the vasoconstriction in the RDP, so that was treated conservatively, and also the marginal indeed was a small caliber, so we did not treat it. Let's move now to the bifurcation. So I've been running a trial. I'm the PI of a trial enrolling 1,600 patients, STEMI patients, and for patients presenting with multivessel disease, we are randomizing angio versus OCT guided complete revascularization. And luckily enough, this patient was randomized to OCT. So as you can see here, before performing the OCT, of course, you need to have some inner lumen. So we did perform a gentle predilatation in order to achieve a good OCT assessment, good quality of images. And we went also in this case for the stage procedure with from a radial approach using an EBU 3.5, 6 French, because indeed the procedure was planned to be a step layered approach for all the reasons you just mentioned. The ostium of the diagonal was not significantly diseased, at least based on the angio. And also with these calibers, I mean, a 6 French catheter would have done the job. So after gentle predilatation, eventually we perform a pullback of the LED to assess the morphology. And you can see here that there's some calcium, but not particularly relevant, not extending to more than 2 quadrants, not extending also in a longitudinal perspective, and not particularly thick. So morphology was not an issue, but morphology is relevant when we consider bifurcation, because when we have a high volume of lipids in the main branch, then we have a risk of plaque shift towards the diagonal. So that's something we should consider. As you consider that, as you can see here, just before the bifurcation, there was a high volume of lipids, and that can increase the risk of plaque shift. That doesn't really happen quite often with the fibrotic plaque. The OCT was used to assess the caliber and the diameters and the length of the lesion at the proximal and distal level. So we decided to after proper predilatation, to implant a trio stents and then post-dilate, performing a POT with a non-compliant 3.5. And this is the result of the OCT after stenting of a main branch. Now you can see that the ostium of the diagonal now looks a bit pinched, at least from an angiographic perspective. There's also some under expansion of the stent in the proximal part. So we proceed with the first rewiring. As you know, you always try to go for the more distal struts, because that's allowed then a good opening of the stents towards the ostium of the diagonal. And the OCT also helps in assessing and confirming the good position of the wire, because with the reconstruction you can see exactly where your wire is crossing the struts towards the side branch. That's a pullback of the diagonal after crossover stenting in the LED, and you can see here that the lumen of the minimal lumen area in the diagonal was particularly small, and also particularly small as compared to the distal part of the vessel. So indeed there was some plaque shift, definitely. So we decided to escalate in this case after proper assessment of the caliber and extension of the disease in the diagonal, to escalate in this case to a 2 stents technique. And the decision was to proceed with a culotte technique for several reasons, because the bifurcation had an angle lower than 70 degrees, and the 2 branches had a similar vessel size, because the culotte technique ensures a complete coverage of the side branch ostium. So after a proper predilatation of the diagonal, then a DES was implanted in the vessel. The second rewiring was performed, final kissing balloon repots, and you can see here the final results.
So this was a single kiss culotte, not double kiss, right? Is that correct?
Was one single, yeah, single culotte.
So I want to ask you this question, because you guys are big into this. Why wouldn't you just balloon the diagonal, put it DCB? Because, you know, these small vessels, they'll come back, they'll come back, they'll come back. You don't want to...
That's absolutely an alternative, which could have been an option indeed. The thing probably is that with some disease, significant disease in the distal part of the diagonal, there could have been a risk of dissection, and but yeah, and indeed, diagonal, the DCB in the diagonal would have been a proper option also in this case. Yes.
I would just like to congratulate you. The result is really nice angiographically, and in my opinion, the the perfusion area of the diagonal is actually, it looks to be large, because this is probably I'm not sure whether this is the single diagonal, but even the sizing is very similar to the LAD. So the question is here, I will just a little bit jump, because we have a bifurcation stenting, and we have a lady with 50 kilograms. When we are thinking it's about and DAPT for somebody like her, do you consider, like, for planning of the bifurcation strategies, the bleeding risk of this patient?
Yeah, that's a very important point. For several reasons, these patients was indeed a high bleeding risk patient because of the body weight. She was, the age was on limit, 72-year-old, so not on the higher side of the scale, but that's something you should consider in planning your procedure. The body weight actually imposed then a lower dose of prasugrel in this case. So the patient was preloaded with prasugrel 60 milligrams, but this is something you have to consider to switch to a lower dose because of the weight.
And for how long have you, planned to go with that?
For 1 year, for 12 months, yeah.
Valeria,
So
go ahead. One quick
minutes.
question before I get Rasi on. Can you go back to the OCT slide about the bifurcation, how you wire? Just explain to the audience, looking at the 3D view, how
Sure.
you know which is your exact. So just explain this slide, this one.
Yeah, thank you. Thank you for asking me that. So basically you have the software can reconstruct the image, and you can exactly see where is the takeoff of the diagonal. So you see here a dot in the angio images, so you see exactly where you are focusing. You have to use all the parts of this slide. So you have a cross section here, and you see that there's a side branch coming up at 7 o'clock, and you have to consider the longitudinal view because you have to double confirm it. And then at the same in the same way, you have to also consider the reconstruction, the 3D reconstruction of the bifurcation, and the upper part of the down part of the vessel. You can use it indeed the cross section to orientate yourself in this figure. The takeoff of the diagonal you can see here because there's an opening of the struts, and the wire is exactly towards this opening. So you confirm that the wire is in the distal cell, in the distal struts, and you cross that. And it's usual when you rotate the image, so you rotate this cursor here that you have in the cross section, then you can flip the image and check the takeoff of the diagonal from another view and just confirm that the position of your wire.
Thank you so much. So, Jolanta, let's introduce the third speaker and let's go to the third case.
Yeah. So thank you so much, Valeria, for presenting this very interesting case. And yes, our third case will be presented by Dr. Maran. So over to you.
Thank you so much. So I kind of thought a case-based review, and I have 3 cases, but I don't have to present all 3 cases. We'll see how the time goes, okay? So it is a 72-year-old male with a history of aortic aneurysm, 5.6 centimeters with unstable angina, history of diagonal stent placed in 2017. He has a EF of 45 to 50%, apical and anteroseptal hypokinesis. His aortic root measures about 4.5, sinus of Valsalva 5.1 centimeters. The cardiac CTA showed moderate left main, multifocal severe LAD stenosis, moderate stenosis of ramus, severe circumflex osteal lesion, multifocal RCA, and aortic aneurysm of 5.1. So hemoglobin A1C was 6.2, obesity 39, BMI of 39, stage 2 chronic renal insufficiency, had liver disease with a thrombocytopenia of 100, OSA, AAA mentioned above, and a frailty score where he needs some amount of help going around the house. So this is his diagnostic angiogram. You can see the kind of coronary calcium everywhere. And the left main disease, maybe a hint of the left main disease, kind of like an ulcerated plaque almost coming up in the distal left main at the ostium of the LAD itself, and kind of a long diffuse LAD segment disease. And RCA, which, it's disease, but not as bad as the left system. Okay. So we had a hard team approach. His syntax 2 score was 47, and for PCI, and 49 for cabbage, and his risk of mortality was 6.17 with for cabbage, long length of stay, morbidity and mortality of 34%, reoperation, prolonged ventilation of 22.7%. With that, we decided to go with high risk PCI. So this is my favorite part, or the most important part. Failing to plan is planning to fail. So my pre-procedure planning, it's an unprotected left main, Medina 111, mildly depressed ejection fraction. LV-EDP was elevated, but he has been on medical therapy with some diuresis, has a history of aortic aneurysm. So you need to think about access. Do we need mechanical circulatory support? What kind of atherectomy are you going to do? And what kind of bifurcation strategy are you going to plan? So in my head, right radial access, let's use a 6-7 French slender guide, use a 7 French guide, do an LV-EDP. If the LV-EDP is elevated, MCS, and if not, just go ahead for PCI. Bifurcation strategy, there is a discrepancy between the left main and circumflex. Usually when there's a discrepancy, I like a DK crush more than anything else. So we start, the right radial artery is non-pulsatile. So we went to a right femoral artery, 7 French approach, extremely tortuous aorta. So we switched to a long sheath. Despite a long sheath, we were unable to get the guide to a good position. The 100 cm guides were hubbed. So then we switched to an 8 French sheath and used a 7 French guide inside an 8 French sheath. So I'll have little room. Actually, I had to use a 6 French guide inside an 8 French and switch to an EBU 4 instead of a 3-5 guide, which I normally do. So these are the steps. I'll go through the steps of the TK crush as I go. This is my guide, and I could not get to the ostium. I just fast forwarded my multiple failed attempts of wiring, and then I was able to free float a wire into the left main and hopefully into the LAD. I love to use the knuckle just so I'm in some part of the coronary safely. And then as you can see, I was not in the LAD, but I'm somewhere, but now at least I can use the guide position and adjust the guide position thing. So I wired the LAD and I was able to wire the side branch. Then the next is intravascular imaging. I have to apologize. I don't have my intravascular imaging. My software does not allow me to do so. But anyway, we decided based on intravascular imaging, stent the mid to distal LAD with a 2.5 by 38 millimeter drug eluting stent. But now you have, and then we are kind of coming up with a proximal stent, but we don't want to do that because we have to start thinking about TK crush. And my LAD is going to be the main branch and the circumflex is my side branch. So we proceed to focusing on stenting the circumflex with a 3 or 12 millimeter drug eluting stent with 1 to 2 millimeter protruding into the main branch itself. So that's done.
Arazi,
Go ahead.
Perhaps just to ask you, you can't show us the OCT images, but can you share with us just about imaging how much calcium was there, what was
So
the good.
thankfully, okay, yes, thank you, yes. Thankfully, it was not, it was just mostly fibrotic tissue, and I did not have a whole lot of calcium. In that way, the process was very easy. My biggest challenge was the axis and the thing. And then you can see there's a little bit of calcium, but there was no 360 calcium. There were flecks of calcium here and there. And I could just prep it with balloon. It's just predilation and not necessarily use any sort of calcium modification for this case.
Okay, super. So go ahead.
So we do the first crush with the 30 NC balloon, then kind of recross and use the choice PT wire and kind of did another kiss again with the 2.20 and 3.20 NC balloon. Took my 4038 stent into the LAD, left main into the LAD overlapping. There you go. That's my thing. And potted with a 5.8 millimeter NC balloon there. And it looked pretty good.
Just ask you also, when do you do your first, actually the crush? Do you size the crushing balloon to the distal vessel size or the proximal, like with a pot balloon? What's
So
your
my pot balloon size was to the left main, whereas my crushing balloon size was to the distal vessel. That's why it was not a big distal balloon, which in my opinion, I kind of undersized it there. And I'll show you why I undersized it, and I paid the price for it later on. Wait, I think I skipped ahead. Yes, this is my thing. My rewiring after my LAD stent and part was absolutely miserable. I had to use a twin pass torque, use a Miracle 3, and I struggled from this step of part to this step of rewiring was absolutely miserable. And I, retrospectroscope, had to wonder if I did not use my intravascular imaging appropriately. And I might have, maybe I was abluminal. I'm not sure. It was an absolute misery to get to this point. Any comments on that as to why I struggled in this specific space?
I think what you need to do is when you do the side branch stenting, you got to bring that balloon back and really dilate it at high pressure, the ostium circumflex. So you really pancake the edges of the stent, when you deploy that stent. And it really sort of pancakes its way out. And then when you use the balloon, the question that Rolanta asked, you should use the size of the ostium up to the ostium of the LED. That's preserved, because you've got a wire across. And use the largest balloon possible. And I think I would sort of have to really crush that really completely. Not only you bring the balloon out to pair open these cells, you're going to crush it adequately to really have a complete pancake. And that's why you may have difficulty rewiring because you might be going abluminal,
Yeah, I actually changed my practice and adopted these techniques, Tanveer. But one of the questions I want to ask the panel also, do you ever use, not for this, like you're talking about pancaking, right? Does an osteal flush ever help you pancake it at all?
No, that's dangerous. You can dissect the vessel.
Okay. So we rewired it, struggled quite a bit, but was able to use a 2.5 in the left main circ and 3.020 in the left main LAD. Then just kind of re-IVIS it and repot it. And this is my final angiographic result in this case. It was absolutely, your point is well taken that I should have used a bigger balloon to have to do my first crush. And I did not do that, and I paid the price for it.
Thank you, Rasi. Just to raise some points, because I think Valeria has a presentation to make after this as well.
Okay, then I can stop and
so each one has a case each. So this is an interesting case. So in terms of when you started off, the guide support, I think you did the right thing to put up a a larger guide, because you're a CTO expert, you put larger guides up to the aorta. You can go up to 60 centimeters. So that gives you a lot of support. EBU 4 is great, but you also have an EBU 5, 4.5 is available too. And sometimes, for the initial wiring, if I can't get to the left main, I put a guide liner up just enough to engage it, and then pass the wire in. And once I anchor it, then I pull the guide liner out, and then, so that's one trick to do it if you can't reach the left main ostium. The other thing,
I don't think I have a EBU 5 guide, but I have 4.5. 4.5. Yeah.
That's
Absolutely.
available. That's available. But sometimes if you can't reach it, I get a guide liner just to tip out enough to get to the left main, have a wire in, and then once the wire is in, maybe I will take a stiffer wire, just to make sure I can get in, and then I'll take the guide liner off and then try to wire the thing. The other thing is, I know this was difficult. You want to get to the case, but don't forget, if you do a good lesion prep, if you have put the side branch stent in the circumflex first, don't forget to do the proximal optimization or bring the balloon back and really blow into high pressure, so you really open up the cells and then crush it, okay? And sometimes you really have to crush the space before you can rewire, and then follow the steps. That's very important.
Yeah, absolutely. I think once I got the wire into that circumflex branch, I was able to wire into the LAD, but just getting a coronary wire into the left main was just absolutely miserable in this case.
Yeah, I think that because you're an expert CTO, to use the Suzuki, twin pass is probably
that comes much more naturally and easily. Yes.
All right.
Okay, I'll stop sharing and we can go to Valeria's presentation.
Jolanta or Megha, Valeria, any questions about this particular case?
No, I think this was fantastic. I was just going to say just a couple quick comments. I think something I've started doing is using a microcatheter up front to wire in, because you sort of have an idea if the microcatheter goes, whether your equipment won't go. But here it was just the wiring that was difficult. And the Miracle 3 is really a nice choice because you have very nice deliverability of equipment over it while being, a relatively safe wire. So I thought that was very clever.
Yeah.
I started for decay crash, even if there's maybe not so much calcium at the ostium, to use anyway cutting balloon from the ostium for the lesion preparation for the side branch, maybe not at the highest pressure, but just to be sure to avoid any issues. And that's at least for the cases I used the cutting balloon, it seems to be really helpful. This is my experience. And as we discussed earlier, if I'm crushing, I actually use this double crushing technique. So firstly, just with the balloon weighting size to the distal vessel, and then I use the next balloon, the bigger one, like the port balloon, to crush the stent completely. And adapting this algorithm really helped me actually to really speed the procedure, and sometimes really following some algorithm makes the procedure really faster. So this is my experience.
Jolanta, you're the second person to describe this cutting balloon. I'm in a different conference. I'm at CVI right now, and that was discussed today, using cutting balloon at the ostium, for osteal lesions and for bifurcation lesions to cut that fibrotic tissue. I would love to hear, has anybody else used the cutting balloon?
I'll come to that. Valeria, why don't you load your presentation while we discuss this? What I've been doing, because the osteal circs restore so high with stents, I actually use shockwave with the ostial circ, not a cutting balloon. I use a shockwave to if there's any amount of calcium, I just use shockwave and post-dilate it with a non-compliant balloon. I've not used cutting balloons for large size side branches, but with the osteal circ, I will use a shockwave. And then, of course, there's studies coming out that maybe just doing single provision stenting followed by drug-coated balloon will be the right thing for the osteal circ because of the motion artifact and the shear stress of the ostium, which can lead to stent fractures. Anyway, so let's go on. Valeria, please talk about your recent paper.
Thank you very much. So it's a great pleasure to introduce these topics on antithrombotic drugs for acute coronary syndrome in women, where indeed myself and Yolanda put a lot of effort in to get to the results of a nice paper. So before introducing the paper, let's first say why this topic is so important, because we all know that even the diagnosis of acute coronary syndrome in women is particularly challenging due to a wide spectrum of different underlying mechanisms, which are not only related to plaque disruption, as is the main common cause of most common cause of acute coronary syndrome in men, but beside that we have plenty of other reasons, most of the time not very well diagnosed. And of course, we have the issue of atypical presentation in women with other than typical symptoms, which also makes the issue, the diagnosis particularly challenging. Let's now focus on the therapeutic and also pathway of these women, and starting from low awareness of their symptoms, then we go through low awareness of different symptoms, also talking about the primary care physicians, paramedics, emergency department, but also women, as you know, in hospital are less likely to receive guideline-directed medical therapy. And let's now go to the issues of undertreatment. As you see here, an overview of all the most prescribed medications in the acute coronary syndrome. You see that women are, for all these medications, including antithrombotic therapy, less likely to receive adequate dose of medications. And that, of course, brings to a poorer prognosis of women, talking about in-hospital mortality, procedural complications, but also at a mid and long-term follow-up. When we look at the results of the major trials investigating antiplatelet therapy, we see that there's no sex-based interaction in treatment effect, and that's consistent in all these trials. On the other hand, we have to bear in mind that the results are different for women and men, and that, of course, we need to take care of the biological and anatomical differences in women. And with all this consideration, we consider a really important topic, and we put a lot of effort to indeed publish this document, which is a clinical consensus statement of the APCI Society together with the ESC Working Group on Thrombosis, which was recently published on European Heart Journal and Eurointervention. And the paper is focused on two main topics. The first one is sex-adjusted treatment, so differences thrombotic and ischemic risk in women, also sex-specific recommendations. And the second, very important, is underrepresentation of women in randomized clinical trials, and focusing on the lack of specific sex-specific analysis. So the goal of this paper was, first of all, to underline that we have a distinct thrombotic and bleeding profile influenced by hormonal status, body size, and comorbidities in women, that we have some clinical gaps related to higher bleeding rates and also treatment delays in women, which reflect not only biological differences, but also systemic bias. And a call to action. The paper urged sex-specific antithrombotic strategy and also an increase and improve of female representation in cardiovascular trials. So putting all these things together, we see that thrombotic risk and bleeding risk are influenced by not only biological, but also anatomical differences. And you see here that the whole spectrum of hormones influence the pre- and postmenopausal phases, but also the menstrual cycle of women, influencing so both adhesion and activation of platelets, the coagulation cascade, and all the factors which indeed may increase the thrombotic risk. But when we look at thrombotic risk, we have to take care also of some specific features which can be found in smaller epicardial coronary artery with an increase in endothelial shear stress, increased lipid accumulation, and also increased risk of, as we said before, plaque erosion instead of plaque disruption. And when we look at the bleeding risk, there are some key features of women presenting with the ACS related to the age, increase creatinine clearance, lower body weight, but also some consideration that we have to make according to looking at the smaller peripheral arteries, so increased risk of radial artery spasm and increased rate of femoral complications. So we came up with some proposal in terms of efficacy in order to reduce the referral time window and indeed ensure a timely intervention for women. Consider intracoronary image to identify the cause of MINOCA. Avoid aspirin for primary prevention in women because it may cause harm, especially in smokers, and also a careful balance antiplatelet agents, especially for all these conditions where we don't have enough data supporting what should be the best strategy, such as SCAT, microvascular angina. And in terms of safety, always adjust the dose of antithrombotic drugs according to indeed what we said, key traits of women, presentation, weight, renal function, and other combination with other drugs. Important point, use of radial access, try to pursue with radial access, use also some tips, for example, avoid cold injection into the radial, use 6 in French. If you go femoral, always you do echo-guided approach, use bleeding score, and also use higher dose of heparin with the strict monitor during pregnancy. And also an important part of the paper is the female representation in randomized clinical trials. So we performed a review of all papers between 2001 and 2021 in interventional clinical trials focusing on antithrombotics therapy. And you see here that 64 articles were included in our final analysis, but only 42 reported sex outcomes, and 8 of them reported sex-specific baseline characteristics. So a complete report of sex differences. And looking at mean enrollment rate, we saw a slight drop of female participants in antithrombotic trials across the years, with an average female representation of 26%, but with a participation to prevalence ratio which is lower than 0.6. These are the trials which reported extensive sex-specific analysis. As you see here, the representation of women in clinical trials is around 25%, so is dramatically low. And these are the recommendations in order to raise awareness about the barriers and propose also some possible interventions in order to overcome these important limits. The barriers start with welfare in order to raise awareness around the need to have more women participating into the trials. This call goes to all the stakeholders in the research apparatus in order to, first of all, start with the proper design of the trial, ensure inclusion of women, so look at inclusive criteria to have women represented in this trial, look for retention strategy, and also sex-based research and sex-based report analysis. And also from the side of the patients, ensure that you have a sex-specific presentation, that the patient is aware herself that we need more data about her, creating some room for, in terms of logistics, broader inclusion, pregnancy consideration, and also engagement of the community. So again, this was the paper we recently published, and I invite you to use the QR code to download the paper. Thank you for your attention.
So thank you very much, Valeria. It's a really call to action. I think we have now the consensus document, and we have to start to use it in the clinical practice, and to leave this and to focus on this gender-sensitive medicine. So, Dr. Rav, would you like to
We're coming to
conclude?
the end of time. Thank you, Megha, Valeria, and Arasi for a great case presentation. Thank you, Laura and Kristen, for supporting it. One question I do have is that, the recent trial came out about low-dose prasugrel after 1 month of DAPT, So are you going to do this now? Or like the trial that came out recently was that give aspirin prasugrel for the usual dose for the first month and drop it to prasugrel alone at 5 milligrams for the rest of the year? Do you think that's something to think about in women and low body weight, Valeria?
That's a great question. Of course, this is one trial. I don't have the answer. I can say that when we look at stopped DAPT 3 and stopped DAPT 2 ACS, a lower dose, too low dose of prasugrel was not a great choice because those trials were negative. But 5 milligrams, I think now we have evidence for a low body weight. So that's something to consider. But that cannot apply to all women because not all women have a low body weight. So that's something I would do tailored.
Great. We've come to the end of time, but thank you so much. And pray for our European colleagues being up through midnight, now probably 1 o'clock in the morning. But thank you so much. Your presence and your paper that you publish are so enormous, and it makes such an impact to the female gender patients who need to be recognized, because more than 55% of our population, at least in the US, is women. And we see a lot of them coming through our ER every day, and they are missed and they're not cared for. And nothing scares me than an 85-year-old woman who's 50 kgs and I can't access the radial artery and body. I know I'm going to bruise her. I know she's going to bleed and she's going to have complications. But anyway, we keep struggling along and we'll keep marching on. Thank you so much for an excellent presentation.